So incidence of shoulder injury, this is an old statistic here. I'm sure it's a lot more than it is that it was at that time, but 13% of all athletic injuries are shoulder injuries. It's probably about 25% now. Types of shoulder injuries, okay, like we mentioned before, there are some chronic injuries and there are traumatic injuries. And so that's why it's key to really find out the mechanism of the injury, how it happened. So AC joint separations, dislocations, labral tears, rotator cuff tears, those are all can be traumatic, okay? Some of these can be chronic as well, but those are mostly traumatic. So AC joint separations, usually I've seen these in a lot of football players come in. Anybody that lands directly on the shoulder, I've seen this in patients that were in car wrecks actually. Their shoulder actually hit a dashboard or a seatbelt. You have an AC joint injury. I see this in bicyclists that, especially they're mountain biking or outdoor riding around Memorial, they'll hit something and flip over their rails and land on their shoulder. That's typically what you're going to find with the mechanism of injury and history with these patients. The different types of AC joint sprains. Not like I confused you guys enough with the 7 different slap tears. Now we're going to throw at you 6 different AC joint separations. The key here is just to really recognize what they look like in the patients, okay? Where they're painful, do they have a deformity in the shoulder? You can have a type 1 AC joint sprain, which is just a typical injury. You see a lot of these. They're just tender here. That just means AC joint got irritated. You can treat this easily in a sling, just rest and let it heal. Type 2 is actually down here. AC joint can actually get disrupted, but these CC ligaments are intact here, okay? That's clavicle still located. So it's still alignment. So the x-ray still looks good, but they're hurting and they're tender and they're swollen. Still, same treatment, sling, anti-inflammatories, do nothing. Type 3 is where the debate comes in whether or not to fix it. I base this on activity level and expectation of the patients. That's when you disrupt basically all the CC ligaments here and you have a dislocation of the clavicle. Type 4, 5, and 6, these are more serious. 4 is when it actually pops through the trapezius posteriorly and it's stuck in the musculature. You have to fix this. It's got to be pulled out and actually reattached. Type 5 is where you have basically 100 or double the displacement. This is completely unstable. It needs to be addressed because all the soft tissues here have been disrupted. And then type 5, I've never seen it, but I've read about it, tested on it, I've never seen it. The clavicle actually dislocates and goes underneath the coracoid here and gets stuck over here. And that actually can cause some nerve issues because of the musculocutaneous nerve and some issues and some neurovascular structures underneath there. But either way, this is something that you just have to be aware of this. Okay. Treatment, like I mentioned before, type 1 and 2 conservative, type 3 controversial, type 4 through 6 surgical. Okay. This is basically a type 3, and this was a football player, type 3 AC joint dislocation, and he had been treated non-operatively, continued to have pain. He was at the point now where he just developed significant weakness, couldn't play, couldn't lift as much as he wanted to, so he opted to proceed with the reconstruction. So this is what it looks like. Now, a type 5 is where it's just twice as high as that. It's pretty obvious. This is what it looks like on x-ray. So this is a type 3. Type 1 and 2, you won't see any step off here. This is a grade 3. This is your scapular-wide view. And you can see here that clavicle and the acromion are not in alignment here. As you can see, the overlap. And this, I'd say that's probably a type 2 acromion. If you look at the acromion, I always tell the residents that are with me and they're looking at x-rays, put their pen or whatever they have up against this acromion on the scapular-wide view. And if you see a little bit of a hook, then it's probably a type 2. If you see a big divot hook, then it's a type 3. If you see nothing and it's lined up with your pen, then it's a type 1, which is nothing. Shoulder dislocations, dislocation of the glenohumeral joint usually occurs in athletics, but it can occur in trauma, from a fall, from a car wreck. 96% of shoulder dislocations occur from forceful collisions, football tackling, falling outstretched extremities, sudden wrenching movement. I've seen some wrestlers that actually got pinned or pulled and their arm dislocated. From basketball, arms get tangled up when they're going for a shot or trying to rebound. So there's a number of different ways you can have a shoulder dislocated. Classification of shoulder dislocation, acute versus chronic, like we mentioned before, differences between dislocators, and we'll talk about that in a minute here. But as far as the direction of dislocation, anterior is going to be the most common dislocation you're going to see. So this is why you want to get more than one view of the shoulder. Okay, obviously that doesn't look normal here on the AP view, but sometimes it's not going to be as obvious. But you can see here the humeral head is down below the glenoid, and then you get, this is an attempt at a scapular Y, and you can see here is the glenoid, and this is the humeral head, and it's anterior inferior, so it confirms that we have a dislocation. Anterior most common. Posterior, you usually see this in patients that have seizures or have been shocked or electrocuted. Other than that, you're not going to really see a lot of posterior dislocations. Inferior, I've never seen this, been tested on it, but never seen it. It's a luxatio erecta. This is actually a patient will walk into your office with their arms stuck in the air and they can't move it, and it's stuck because the humeral head is jammed underneath the glenoid and the coracoid, but I've never seen it happen. Anterior dislocations, like we mentioned before, we talked about the labrum structure, the glenoid. Bone is glenoid, labrum is the bumper around. When you have an anterior inferior dislocation, when the shoulder knocks off a portion of that glenoid, like I mentioned before, the golf ball, golf tee analogy, when that golf tee is chipped, that ball is going to roll out anteriorly, inferiorly. So this is what we fix. This is the soft tissue and the labrum that we bring up, and we reattach it to the bone. So it gives us back our conformity of the cup, okay? This is a bony Bankart. Bankart just means a detachment of the anterior inferior labrum, and a bony Bankart means that they have a small fragment of bone with it. Hill-Sachs lesion, like I mentioned before, if you have a dislocation of the humeral head, falls out, this little divot here of the glenoid embeds itself in the humeral head, creates an indention in the humeral head, and that's a Hill-Sachs lesion. So what do? Well, you want to immediately reduce the patient. As far as what to expect from these patients that are dislocators, if they're younger than 20, they have about a 70-95% risk of recurrence. So these patients that think that, oh, I'm never going to dislocate again, if they're younger than 20, it's very rare they stop dislocating because they definitely recur. They have to do with their ligamentous structure or the ligamentous laxity, but they usually recur. Most common complication is axillary nerve palsy. This is actually because they stretched out the axillary nerve, which is inferior. If it's greater than age 40, it's high incidence of rotator cuff tear. So I have a patient that dislocates their shoulder that's my age. I'm thinking that they got tore a tendon. If there's a high school student that comes in, then more likely it's a labral tear or something along those lines. Surgical management, repair of the labrum. As far as what to do, these are just some basic pictures here of what it looks like arthroscopically and what we're seeing. This is the glenoid here, this white cartilage. This is the labrum here. You can see where it's detached. So basically what we do is we basically pull it off and then repair it. So this is actually what it looks like. There's bone here, labrum here again, and you want to reattach that to that, okay, here to here. This is just an MRI showing you a labral tear. Like I mentioned before, treatment, arthroscopic Bankart repairs, where most people are doing this nowadays. It's becoming the standard of care regarding recurrent instability in the shoulder with a labral defect. Open Bankart repairs are still doing these for revisions or patients that have failed arthroscopic, or there's still some guys that still want to do capsular shifts and open Bankarts, but more and more guys are doing arthroscopic nowadays. Rotator cuffs. Rotator cuff injuries usually result from high forces. Like Adam had mentioned before, it's always during the deceleration phase of throwing. I think he mentioned the biceps getting injured with that, but also the tendon, the supraspinatus and rotator cuff tendon. That's when it's actually going to be more prone towards injury, is during that phase of throwing. Treatment of rotator cuff tears. If we look at these tears, usually majority of these we're going to treat with non-operative measures, which is therapy, injection, and PRP. I got them in mention. But if they do fail that, then we got to look at it, look at the tendon. And sometimes we'll see these partial tears. Now, if a partial tear is less than 50%, these patients will actually get better if you just debride it and and leave it alone. You don't have to fix it necessarily. You just have to remove some of that degenerative tissue and see if there's any other pathology, such as acromial spurs or bursitis that you need to take care of. And they actually have pretty good results with that. If it's greater than 50% torn, we'll actually repair these because the likelihood of it progressing to a full tear, if it's greater than 50%, is high. Okay, so we want to go ahead and take care of that while we're there. Types of shoulder injuries, non-traumatic type of injuries, instability, cuff tendinopathy, and impingement. These all occur a lot of times from chronic issues. Multidirectional instability, this is what we just talked about a second ago. Common in swimmers, volleyball players, and rowers, because this gives them a mechanical advantage to get that arm backward and get that extra velocity in their stroke or in their throwing. So anterior and posterior laxity is what it means with multidirectional instability. That means they're loose in all directions. So atraumatic shoulder instability. This is laxity in other joints. This is like Adam had mentioned before about the Marfan's and Ehlers-Danlos. It basically means that these patients are prone to instability in all their joints because their ligaments are so lax. I mean, they can bend their elbow back, 45 degrees, or they can bend their thumb back to touch their forearm. They're going to be prone to shoulder dislocations. They're going to be prone to instability. These are patients that strengthening is so key. It's they just have to understand that. I mean, there's no quick fix for this. They just really have to work on the musculature and the balancing act of their body. So, treatment, like I said before, rehab, emphasizing rotator cuff, scapular stabilizing exercises. That's definitely for the shoulder to help balance out the shoulder. Cuff tendinopathy. Adam did a good job of describing the difference between tendonitis and tendinopathy. Most of the problems we see are tendinopathy. Tendonitis may be just the acute phase of it. The tendinopathy is kind of the long-term result of degeneration within the tendon itself. Common in athletes with multidirectional instability. I mean, think about this. These athletes that have these shoulders that are unstable, their muscles are working overtime. So the tendons are constantly getting stressed, and so they're going to develop a tendinopathy, and they're going to be at higher risk for that. Rotator cuff and biceps tendon are dynamic stabilizers of the shoulder. Usually these are the places that you're going to see most of your injuries regarding the tendinopathy. You're going to be the rotator cuff and the biceps tendon. So usually they become injured. Secondary to tensile failure, like I mentioned before, these muscles are working overtime trying to stabilize that shoulder because of the laxity that they're compensating for. So they're going to fail because of tensile failure, overworking. Symptoms of this is what we look for with cuff tendinopathy: pain with overhead activity, weakness with external rotation, pain with internal rotation at 90 degrees abduction, proximal biceps tenderness, scapular wicking due to atrophy. So always remember, look at the scapula, look at the balancing of the shoulder, make sure they're strong in every plane. Treatment: cuff stabilizing program, strengthening that rotator cuff. Working on the scapular stabilizers, working on the parascapular musculature, the scapulothoracic junction. Anti-inflammatory injections. So all these are non-operative. The majority of these are non-operative. We get very good success rates with just sticking with this program. The problem is that a lot of people don't want to do all this stuff. So they want the quick fix, but unfortunately, you just have to explain them and educate them that they do have to work at it. And if you're working with them on a preventative aspect, you're helping them prevent from getting injured in the future. Primary impingement. This is basically secondary to compressive mechanisms underneath the rotator cuff, underneath the acromial arch, which is that CA ligament that I mentioned to you before, which you guys saw in the anatomy picture I showed you at the beginning. This is it again. Here's the coracoid. Here's the acromion. This is the ligament up here. So when they reach back and they externally rotate, abduct the arm, that's right underneath there. So sometimes if you have any kind of spurs or anything like that, or any kind of injury in this CA ligament or fraying in that CA ligament, you can cause a bursitis or an irritation of the rotator cuff tendon. Impingement, entrapment of the rotator cuff in labor during the leg cocking or early acceleration phase. This is internal impingement. Okay, what Adam had mentioned before as well. What happens with internal impingement is actually when you have this imbalance in the shoulder because of the tightness in the posterior capsule and the laxity in the anterior capsule, over time, the body just kind of gets used to it. So if I look at a pitcher, you know, and they put their arms out side by side, one arm, their pitching arm's going to have the external rotation like this, and their other arm's going to be at 90. And then they're going to go internal rotation, and their internal rotation on their left arm's going to be about here, and then their pitching arm's going to be around here. So that's an imbalance in the shoulder. And that means that that posterior capsule is incredibly tight, and the anterior capsule is incredibly weak. So your job is to balance that out. Make sure you stretch out that posterior capsule. Work on the sleeper stretch that I mentioned before. Have them lay on the table, bring their arm up at their side, grab their arm here, push on their arm, and actually that helps stretch out that posterior capsule. And it's a great stretch that they can work on, especially the throwers. Arthroscopic debridement, anterior capsulorrhaphy. I think that this is kind of falling out of favor nowadays. Some recent studies are showing that patients are doing much better with actually rehabilitating this and actually balancing out the shoulder. We're only doing this in really extreme cases.